Join Drs. Savannah Craig and Ronnetta Sartor as we navigate life beyond graduation. Real conversations about forging our own paths in our early years, in our careers. There's a reason it's called practicing dentistry. All right, so today's topic is some of the myths or some of the things that you're taught in dental school that then once you're out in private practice, you realize either there's an easier way to do these things or, you know, a more updated way to do that. So I'll present you some of the topics that I find super interesting, and then you let me know what your takes on them are. Sound good?
Sounds great.
So one of the biggest ones in residency we always talked about was like use of septocaine in IAN blocks. What were you taught in dental school about septocaine?
Well, it depends on who it's teaching.
Always.
Yeah, I feel like the oral surgery people were just like, use whatever you can to get it numb.
That's a great perspective.
In not so many words, you know, but pretty much it was just like, you know, if you gotta get it numb, you gotta get it numb. But we definitely had a lot of professors that definitely were not on a septocaine train. And I think even when we took our dental boards, there were stipulations on, you know, septocaine use and all that sort of stuff. What were you told? Because you know, I went to dental school in South Carolina, and you know, you went. Where'd you go?
Ohio.
Yeah, in Ohio. So a little geographical difference. But I'm curious to hear what you were told.
I mean, we were definitely told if you give a block with septo, you're gonna have paresthesia. You're gonna, you know, go directly to jail. Do not pass go. Do not collect your $200. And then I got to residency, and they're like, "Do you know what that like fact was based on?" And I was like, "I thought research." And they're like, "Well, actually, it was based on like an advertisement like against septocaine, and it's not actually based in a whole lot of logic." And I was like, this whole time I've been afraid to give a septo block. And then you start doing it and it's so much faster, and I feel like it, you know, I can be a little more off on my blocks and people still get numb. So then when I got to private practice, I started doing that, and people were like, what are you doing? Like, people are gonna, you know, lose their whole mandible. And I'm like, guys, it's okay. So the myth has followed me forward. But do you give septo blocks?
When needed, yes.
When needed.
Yeah, when needed.
So you'll still give a Lido, and then okay. And then if they're not numb, what do? Do you give another Lido, or do you go back with septo?
Whatever's indicated. Whatever's indicated. But I say that to say that pretty much I am not like afraid to use septocaine.
Yeah.
It's something that I use every day.
Yeah.
I think it just depends on the case, you know.
Always.
You have some patients who, when they sit in the chair, they tell you, hey, I'm going to let you know right now, it's really hard for me to get numb.
Yeah.
And those patients I treat a little bit differently than the ones that I've seen already, and we haven't had any trouble in the past.
Yeah, but that's fair.
For sure, like, it was the same thing. It was like Shell, you know, definitely shocked for real when I got into residency and they told me the same thing. It was just like, oh, okay. Well, let's try it out. And, luckily, there has not been any adverse reactions to it in the ways that, you know, we were told in dental school. So,
yeah,
that does not mean that there aren't some people out there that have experienced paresthesia and stuff.
For sure.
In my experience, I have not personally experienced it.
You've not burned into flames from giving a septo block.
No. What's next on your list?
I think the other interesting fact from like dental school was about treatment of pregnant patients, and, you know, they can have nothing, you can do nothing for them. And then again, you go to residency, and we had a attending whose um, wife was an OBGYN, and she gave us lectures and basically was like, yeah, we give them narcotics. We give them, like, if you're in labor, and nothing bad happens. And so I think it was really eye opening to me of just like, I think poor pregnant people have not been like used in research for obvious reasons, but so we just
Mm-hmm.
treat them like they're so fragile. And what has been your experience in your practice of
So I'll start by saying in residency, and it may be because we went to the same residency and the same person taught us the same things, but pretty much I'm just gonna echo what you said. But I think when it comes to pregnant patients, I tend to put myself in their shoes
for sure.
a whole lot, and if I think, okay, well, if I was someone that was carrying, another tiny human inside of me, I would err on the side of caution.
Yes.
So a lot of times I'm more conservative in what I do. I think
Mm-hmm.
it's been proven that the second trimester is the safest time to do things of dental nature. But a
Mm-hmm.
lot of times I, you know, talk to the expecting mom and let her know, hey, this is what we found. This is what could maybe wait until after you deliver the baby. This
Mm-hmm.
is what we probably absolutely have to do now so that it does not affect your baby. Because,
Right.
we practice more now in terms of evidence-based dentistry, and there are lots of things as it pertains to the mouth and oral health that could impact the baby. And so I'm just very candid with mom about that, and ultimately the decision is mom's, but it's no pressure for me
For sure.
on treatment and that sort of thing. But I'd say that I'm still very um cautious. But if a mom comes in and she's in pain and she has an infection, we
Yeah.
definitely want to get that treated.
Yeah.
um but yeah, it does make me less anxious and nervous kind
Yeah.
of than I was in dental school, because it was almost like, oh, like I almost, like, I was so scared in dental school. I don't know that I wanted to like treat any pregnant patients, because
Yeah.
they just made it out to be such a big ordeal sometimes.
Agreed. Agreed. And it's like, you know, obviously every situation you're weighing risks and benefits and all of those things, but yeah, I've in residency we had a couple of instances of patients in pain and infection, and they're like, nobody will help me. Like, I can't live like this for another however many months until this baby
Right.
comes. And then I think we had also seen a lot of people who sort of had to put off or chose to put off treatment, and then now they have a baby and they don't have the
Mm-hmm.
time to come in for the care that we deferred. So I think it's like you said, it's really a conversation with mom of like, as far as we know, these things are safe. These are the biggest concerns, but we're willing to help you. And I think a lot of people are just looking for someone that's confident that they're going to be okay if treatment needs to be rendered.
Yeah, for sure. Like, no one wants to go to someone that they deem to be an expert, and the expert's nervous. Like,
Right.
that does not that does not help the patient to be not anxious about treatment if you're anxious about it.
Yeah.
Yeah.
Yeah. I think another interesting point on this topic was having, they recommended in residency, like asking them how the pregnancy is going, because I think all of our brains try to make like connections between things. And so if you can be like, you know, if there's already some complications or concerns about the pregnancy, and then you do treatment and something goes on, unfortunately, people tend to make that connection of like, oh, well, I had, this treatment. And so I think that's something I think about a lot, is just making sure you know the lay of the land, and let you know there are potential complications with any any healthcare procedure. We're not immune from that in dentistry, but I think it helps to make that decision a little more of an informed decision for you and the patient.
Right, and it goes back to like what we've all learned is that you never treat a stranger. So
Yes,
you need a thorough medical history on anyone that you're doing treatment on, and pregnancy and the details, and whether there's been any complications with it is one of those things that's on that list.
for sure. I think that's a good segue into my other topic of ideas is um, cardiac patients, and the myth, alleged myth that we were taught in dental school that then residency was like, is only allowed 2 carpules of anesthetic with epinephrine in cardiac patients. What's your thoughts about this topic?
Well, I guess tell myself and the audience what you were told in terms of that.
So in dental school, basically, if your patient has any sort of cardiac condition, previous heart attack, they're on, you know, uncontrolled hypertension, stents, any of that stuff, that patient is allowed 2 carpules of lidocaine with epinephrine, and that is it. If they're still not numb, we're deferring care today. And then in residency, they were like, it's, epinephrine does not last a whole long time. Your body actually produces more endogenous epinephrine from being anxious that you're at the dentist than necessarily the 2 carps are gonna, increase the body's epi. And so their recommendation was, don't give 10 carps in a row, but give 2, monitor the patient. If heart rate is stable and they're feeling okay and no chest pain and they're still not numb, you can give a third. You know what I mean? Like it's not as an exact maximum as we were portrayed it to be in dental school.
Okay. Yeah, so same along the same lines. And I again we were taught by the same people. um but that definitely has worked for me, and I will say that if there is a patient that has lots of cardiac issues, and I definitely get that thorough medical history in terms
Yeah,
of like what cardiac issues they have, and use my judgment in terms of whether I deem that I'm comfortable treating that patient
for sure.
in my office, or whether I think it would be best due to their medical history that they're seen by a specialist.
Mm-hmm.
Um, and sometimes that is the case, and I explain to the patient why I feel that way.
And obviously, full mouth extractions versus an occlusal filling
Mm-hmm.
is
Right, for sure.
wildly different.
Mm-hmm. Yeah, I think on that one is one of those things where it's a double-edged sword, right?
Mm-hmm.
Because if something is to happen, and your notes are subpoenaed,
Right.
and you have an ear that you just like slammed them with 10 carbs, like you're in trouble.
Yeah.
It's not going to look very good for you. So I think part of it is, a lot of what, yeah, a lot of what it's like we live in a completely different time now where like
Yes.
if an adverse reaction were to happen, we're more likely to be sued than say 30 or 50 years ago.
Yeah.
So it's one of those things where, because dental schools teach it and that sort
Right.
of thing, it's like if something happens there, you want to make sure that you're covered and you're doing no harm, if that makes
Right.
sense.
Right. I think the other thing I on this topic that I like flip back and forth between is the balance of my patient not being profoundly numb and that strain on their heart and their body versus giving one more purple of anesthetic. You know what I mean? And there's no right answer there, but I think that's like the debate I have in my own brain.
And then the other part that you kind of brought up and they brought up when we were in residency, just the basic fight or flight response.
Right.
You know, how much epinephrine is the body pumping out? You know?
Because they're in my chair.
Right.
Because they're hanging out with me.
Mm-hmm.
Yeah, so I think, and I think that's my favorite part of residency was like, we had the chance to see such sick people. And I mean, that's not special to residency. You know what I mean? Like, there are people in private practice who are going through it and have a lot of medical diagnoses. But I think it makes me more confident because we saw such medically complex people in the hospital or coming to our clinic or in the emergency room that I'm like, okay, if, you know, Mr. Jones from residency had an LVAD, you know, and we gave him some Lido with Epi and he was okay. You know, Mrs. whoever in my private practice who, you know, is on some blood thinners, she'll be all right. And I do think
it brings up a good point too. Like, if you have any question about it, you can always have a consultation with their cardiologist. You can always going back to, you know, pregnancy, always have a consultation with their OBGYN. Like, I think in dentistry sometimes we feel like we're on an island, but every cardiologist I've ever talked to, every OBGYN, every primary care physician I've ever talked to, none of them have like shooed me away. We have the same goal. We want our patient to be healthy. And it's been welcomed every time that I've tried to reach out to make sure that we're doing right by our patient.
Yes. And I do think that was another point that I learned a lot in residency was, you know, we're all on the same team here. And also, a lot of medical providers don't really know the extent of what we do. And so I've tried to like speak with them in person or in email and explain, you know, this is a full mouth extraction. It's going to involve, you know, a flap across their maxilla and, you know, some significant bone reduction. Like, this is major surgery. And so, you know, that's a different conversation than, you know, we're taking out one perio involved tooth. And so I think it's a specific balance of, you don't want to insult anybody's intelligence or their experience of dentistry, but being very clear of what you need to do and how extensive it can be so that they, you know, just they have all the information that they need to help advise you, I think is tricky sometimes.
For sure.
Because they're just like, oh, they're going to the dentist. They're fine. And you're like, this is going to be a lot. Are they going to be okay?
Right. I think this topic leads back to one of our past episodes, which was continuing education. So we're both talking about residency and education that we received after we graduated and the importance of it and how we've learned to practice and how we've learned to better serve our patients because of it. So in dentistry, it's all connected, and that's what makes it such a beautiful profession to be in.
Awesome. What a great way to wrap it all up.
Thank you for joining us for this episode of Beyond Graduation. If you enjoyed this week's episode, be sure to share it with a friend. Connect with us on social media at Savannah Craig DDS and at Dr_Sartor. And remember, you are not alone on this journey.
This episode was sponsored by the Dental Residency Guide and the Beyond Graduation ebooks. These ebooks can be found at ignitedds.com/ebooks.
Thank you so much for listening to Beyond Graduation, brought to you by Ignite DDS and Future Dentists.